Hello, welcome back. So in the basic science, next we'll be discussing the soft tissue injuries. So soft tissue injuries is one of the commonest injuries you might have experienced is the sprain or the ankle sprain if you play football or any other sporting activities like the badminton, etc. So what's a sprain or how is it differing from a strain? So sprain is an injury to a ligament, whereas strain is to the injury of a muscle. So sprain, the definition is it's injury to a ligament. I hope you know what is a ligament, because a ligament is the connective tissue between two bones, whereas tendon is the connective tissue between muscle and a bone. So that's the basic anatomy. And pathologically, the ligament can be torn from the bony attachment. So it is known as an avulsion. So it can be either torn from the bony attachment or bony insertion, or in between the substance or mid substance tier. So these are the pathological changes happening at the or during the sprain. And again, you can build on the short note by classifying the sprain into 3 types or 3 degrees or 3 grades 1, 2 and 3. Clinical features, of course, you will have some pain, some amount of swelling at the injury site, and you can do some stress test. So you can in the diagram over there, there is the knee joint is being depicted here, and this is the site for MCL or the medial collateral ligament. So the stress test is that if once the MCL is torn or it is being injured, once you give a valgus stress, so a direction opposite to the injury, or the injured ligament, so medial collateral ligament stabilizes the medial part of the knee. So if MCL is torn, if you give a valgus stress, the medial side will open up. That is classically depicted in that figure or this. So stress test is an important clinical test in case of a sprain. And radiology, in case of an avulsion fracture, you can make out some bony chip being pulled off from the bone end, or sometimes the joint becomes unstable in case of a grade 3 injury, but otherwise the x-rays in most of the scenarios will not show anything. And the treatment part, the first degree sprain, you give RICE. The famous RICE is rest, immobilization, cold compress and limb elevation. Sometimes people add PRICE, P along with that, which is the painkiller part. Second degree sprain, you have to go for some splintage or plaster of Paris application, so that some amount of immobilization required. And grade 3 sprains, again immobilization versus surgical management has been the treatment. So it's a very simple topic, but once you are being asked to put it as a short note, there arises some difficulties, some problems. That's why I have discussed it in detail. Now the classification, if you want to elaborate a bit more, the grade 1, grade 2 and grade 3. So in grade 1, there is only a tier of a few fibers, so that the weight bearing, in case of an ankle sprain, the weight bearing is okay. There is no pain on weight bearing classically. But in grade 2, there will be a partial or complete detachment of the more ligamentous fibers, so that the weight bearing becomes difficult or painful. And with grade 3 or third degree sprain or complete sprain, the joint will become unstable. So this is how you can differentiate the 3 different grades of sprain. And the MCQ related, this is a very classical MCQ, again repeatedly being asked. The most common ligament injured in ankle sprain is the anterior talofibular ligament. So that is the lateral part of the ankle. Anterior talofibular ligament is the, so even whoever who injures their ligaments during the sporting activities like the football, the badminton type landing, so it's commonly the anterior talofibular ligament of the ankle really gets affected most frequently. Now the strain, so strain is injury to the muscle or the tendon, unlike the ligaments in case of a sprain. Again, pathology is sudden vigorous contraction overstretching. If you going to play after an interval or after a gap of 6 months to 1 year time, suddenly you want to stretch out yourselves, the muscles get torn. So that's classical, the sudden vigorous contraction or overstretching of the muscles beyond the physiological limits. Again, you can classify it 1, 2, 3 and 4, unlike the 1, 2, 3 in grades in sprain. And clinical features, pain of course will be there, swelling of course will be there, but sometimes there will be inability to move because of, in case of a higher grade of muscle strain injury. Radiologically, if it's avulsion, there will be some bone fragment being avulsed, which can be made out in the x-rays, but otherwise USG or MRI has to be done to elaborate on the soft tissue details. Treatment, of course, most of the strain or even 90% of the strains get healed. Strains will heal by rest and immobilization, because the muscle has got tremendous amount of vascularity, where the healing is not really a big issue. But sometimes surgery is required in case of a big avulsion injuries or the grade 4 strains. So I have written a small algorithm over the screen, which once the injury occurs, it is the pain mechanism or the pathophysiology in case of a strain. So if you want to elaborate or make your answer more attractive, you can under the pathological part, you can draw this diagram. Once the injury occurs, there will be pain and reflex spasm. Pain causes reflex muscle spasm. Again, this will stimulate a pain fiber stimulation, which enhance. So it's a vicious cycle of pain and spasm interconnecting, which is associated with the pathophysiology of a muscle injury or a strain. So just a few words regarding the different grades or different degrees of muscle strain. In the grade 1, only a few muscle fibers are torn, whereas in grade 2, more fibers are torn, but still the fascia is intact. In the grade 3, the fascia is partially torn and more than one muscle group is affected. And in grade 4, there is complete muscle rupture and complete facial tear. So it's just an increasing grades of severity. You can see over the diagram, the biceps muscle has been avulsed from its insertion at the humerus. So this is strain and sprain. It's just a common sense only, but once you have to build a short note, you can write like this. Now, myositis ossificans is again one of those frequent short notes which we have noticed. So it is just the ossification of hematoma around a joint. Actually, myositis ossificans itself is a misnomer. Myositis itself means inflammation of the muscle, and the muscle gets ossified, but it's not the muscle which is getting ossified, or it's not an inflammation of the muscle. It's just a, it's just kind of a metaplasia kind of thing, where the hematoma following an injury gets ossified to form a bony mass. So the causes or the etiology can be either traumatic, which follows an injury, which is the commonest cause, commonly seen around the elbow or the hip, like your supracondylar fractures in children, which can future lead to elbow stiffness, and the cause can be myositis ossificans following a trauma. Sometimes it's seen congenitally, which is known as a myositis ossificans progressiva, one of those MCQs being asked. So this forms the two causes for myositis ossificans. I told you the common locations are the elbow and the hip joint. And clinical features, there is painless loss of motion. I told you once the fracture is healed, then only this will start appearing, so that the elbow will be stiff, but it will be painless. So the painless loss of motion is the classically finding myositis ossificans. And X-rays, you can make out the bony formation in the X-rays, and alkaline phosphatase, that is the buzzword for myositis ossificans. In the investigation part, alkaline phosphatase must be there. So alkaline phosphatase increased activity means that the myositis ossificans is still active phase, so that you should not attempt any surgery, because any soft tissue further injuries can further stimulate the bone formation, so that the disease can even recur after the surgery. So alkaline phosphatase is a separate investigation apart from the X-rays in case of a myositis ossificans. So please register alkaline phosphatase in your brain. Management, avoid massaging after trauma, which has been a frequent cause for all those, these traditional bone setters do all those massaging at the time of injury, causing further soft tissue trauma, and stimulates the soft tissues to in the lineage of bone formation. Of course, indomethacin and some amount of radiotherapy has been helpful, which can be given prophylactically even before in cases of elbow injuries or hip injuries, where you suspect a case of myositis ossificans in the future. And bisphosphonates, of course, has been found which inhibits the osteoclast formation function, has also been found useful in case of a myositis ossificans. So if you can remember indomethacin and radiotherapy, at least it would be really useful in case of the management. I have written two yellow rectangles with some buzzwords. High incidence of myositis ossificans has been seen in brain or spinal cord injury due to some unrelated factors, where the differentiation into the bone tissues has been found quite frequently. So you have to note that point, commonly seen in people with a neuronal or patients with neuronal damage like the brain or the spinal cord injuries. And there is one famous Ackermann's zonal phenomenon. Zonal phenomenon means that the myositis ossificans, it matures from the center to the periphery. So it's kind of a the center will be immature, and the mature part is the periphery, just the opposite of malignancy, where you can have a reverse zonal phenomenon. So this forms a part of your maybe general knowledge, or sometimes can even be asked for your exams. Reverse zonal phenomenon, which is seen in case of malignancy. So the zonal phenomenon is seen in myositis ossificans, where the central part is immature, whereas in malignancy the peripheral part is immature, so that your biopsy will be easy. You can just go through the superficial part of the lesion and take a piece for biopsy. So that is the myositis ossificans, and some of the MCQs has been asked regarding myositis ossificans. Most common site of myositis ossificans, of course, I have been repeatedly telling, it's the supracondylar fracture of the humerus, and it's thus the elbow forms the answer. And in myositis mature bone, I discussed now Ackermann zonal phenomenon. The mature bone is seen at the periphery, whereas the central part is immature. So these are the few soft tissue injuries that has been coming under the topic of basic science. It's quite easy, sprains, and you have seen, you have come across all these injuries even in your personal life or even your friends, relatives quite frequently. So I don't think this will be a difficult part to learn. Thank you.
Docemy.